Well, good evening, folks. Welcome to Dentist in the Know. We are your backstage pass to all the trends, politics, current issues, and education in dentistry. It is live, it is Wednesday night, and it is usually over a cocktail. However, tonight we're doing something a little bit different. We've been doing a few of these lately, but this is really a forward facing, consumer facing episode. This is a podcast where real dentists pull back the curtain on everything you thought you knew about oral health and everything your dentist wishes you knew. We're here tonight to break down the myths, answer the questions you didn't even know you had, and help you make confident choices when it comes to dental care. There's no jargon and no scare tactics, just real talk, real science, and a healthy dose of humor. So tonight I am Dr. Chad Duplantis, and I am joined by one of my best friends in the dental industry, Dr. Jennifer Bell. I'm from Fort Worth, Texas. Our good friend, Dr. Jennifer Bell, is from Raleigh, North Carolina. And our other friend, Dr. Jeff Horowitz, is flying somewhere right now from Myrtle Beach, South Carolina to Las Vegas, Nevada. And we're just honored to have each of you here with us tonight. And hopefully we can answer some questions. We're going to talk about a bunch of different things. We do these episodes for dentists, and then we also do these episodes for patients of dentists. So, JB, how you doing tonight?
I'm good. How are you?
I'm good.
You've been off on some travel. Can you talk to me about Texas Dental Association? Like, what's going on?
Well, politically, I have no clue because I wasn't involved in any of those meetings. But Texas Dental Association, most of these state dental associations, for those of you that don't know, have regular annual meetings. And so their annual meeting was this past weekend. And it's a great place for dentists to convene, to gather, to discuss, to learn, all of the above. And then there's a little bit of politics, not like social politics, but dental politics, which is really politicking. So it was a good meeting, So,
I can only
Texas
imagine.
is a large state. California's is this weekend. Yeah. So I wasn't involved in any of those discussions.
Are you headed to California, CDA?
Absolutely not. No. Are you?
No. Not that I wouldn't go. It just, not teaching. So.
Yeah, California is a fascinating meeting. They actually have two. They have Northern and Southern California, CDA North and CDA South. So I don't know which one is this weekend. I believe it's North, maybe.
Can we just take 5 minutes? We've had some amazing sponsors come online, and I would love to give a little love to them because, quite frankly, without them, we would have been shut down by now. So we have some new folks coming online. We had a fantastic episode with Dr. Burton last week with Garrison Dental. Like, I went back and rewatched it again, actually, in preparation for tonight's show. And it's just so fun to watch dentists that are so excited and enthusiastic about the things that they're active in. And honestly, it's really fun to watch dentists trying to make the dental profession a lot better. And we all do it in different ways, right? We do it through organized dentistry. We do it through teaching. We do it through product review. But for Dr. Burton, it's doing it through innovation, which I just think is super cool. So that was really great. Of course, we have Ada and Ada Education, a big partner for Dentists in the Know. Happy to see them continuing to have a journey with us and bringing fantastic education and membership benefits to members and Dentists in the Know. We've got Align, Pearl, Curve, Mango. I mean, the list goes on and on of the number of folks that are coming online. Kettenbach, a new sponsor that's joining us this year. We're really excited. And did I mention our first webinar next week, May 20th, with one of our former guests, Dr. Joy, will be joining us. And drum roll, Dr. Tom Viola is coming online to join us on June 5th for an opioid course through our webinar series as well. So I love what's happening. It's so fun. So fun.
Well, I think that one of the things that sets us apart from uh, some other groups is that we really vet all of our sponsors. We work very closely with all of our sponsors. We don't just take on anybody. And the people that do come in and join our group are very well known within the dental industry, very well respected, and it's an honor to have them as part of our team. So I want to
100%.
once again also thank all of our sponsors. And actually, we would like to refer to them as educational partners, because we aren't where you're going to go for the deepest discounts, but we can promise you that what we will bring you vetted, authentic, and you gotta love the internet. God bless
Man,
America.
it's
Thank
really
you.
bad. And but what I will say too, 9 times out of 10, most of the companies that we actually work with, we have relationships with. Like these, I'm not looking at 30 website companies and then just bringing you the one that I like the most. The majority of our educational sponsors, I might say all of them, at least one of us is a client or uses the service or has some affiliation with the company. So not only are they vetted, but there's long-standing relationships of how they take care of their customers and their people. So it's really exciting to continue to be a part of it. And we've got some really exciting ones coming online very soon.
That is exciting. Yes. I think it's going to be great. I think it's going to be great. So, do you have some news for us this evening, Dr. Bell?
Of course, I always have news. What would another day in the world of this new administration be without a lot of activity? A lot never fails. Are you ready? Shall we
I'm ready.
continue?
Shall we? I'm going to
Okay,
drop myself.
you got it. Let's get to it. All right, team. Lots of activity happening in the world of dental news. So, a few things that we think you should know that's happening in the government this week. First and foremost, huge buzz happening around RFK and the fluoride debate, and also a lot of other pieces of suggestions that have come forward in the oral health world. We'll talk about that at the end of the news segment for today. But first, let's talk about the few things that have been brewing back up again. Happy to see this one coming back to life. We talked about this. I'm going to have to go back into the old archives to see. I want to say it's been almost 2 years since we've talked about the Ensuring Lasting Smiles Act. It's an ADA supported bill that is trying to push forward legislation that will require insurers to cover congenital defects. So, my friends out there that are missing 7 and 10 or other teeth, and the insurance company kicks it back as a cosmetic makeover when you decide to restore back your teeth because you were congenitally missing them. This is the act we've been waiting for. This is to help move forward legislation that will require insurance companies to recognize those congenital defects as not aesthetics, but restoring back to proper function and allowing us the opportunity to restore these patients under covered benefit. So I'm really excited to see that one come back online. It was introduced a couple of years ago. It fizzled, disappeared, have no idea where it went into the archives of legislation, but it's brewing back up again. So we're excited to see that. Another big discussion point for the week is student loan repayment options, curtailing interest capitalization, a bunch of items around those programs. Also, public service loan forgiveness programs as well. A lot of interest is being drawn because of the Department of Education is now looking at all of these different programs. There's open comment periods and opportunities for discussion on that. So we're continuing to watch that and making sure that, dentistry is at the forefront. We know these loans that dental students are taking out are very sizable in nature, but many of the loan repayment programs actually penalize them because of high earned income, even though the loans are fairly substantial. So we're continuing to watch that to make sure that we can offer public service loan repayment programs and other things to help dentists choose alternative paths for loan management. So interestingly, there's been a lot of open debate over the last couple of days about fluoride. We know this has been a pretty active discussion. Lots of talking points have been bubbling up, but there was a hearing as of today. It was the HHS fiscal year 2026 hearing, the budget hearing. There was a lot of discussion actually about ingestible fluoride. So, a lot of the current debate within Facebooks and different platforms amongst dentists and their communities has been focused a lot on municipal water supplies and fluoridation of those water supplies. But today we saw ingestible fluorides coming online as well. There's a lot of rumble about suggestion that these will also be eliminated, that they will no longer be accessible through pharmaceutical means. I think we can certainly debate what the efficacy of those are, and with the onset of municipal water sources being fluoridated, I think a lot of clinicians have gotten away from ingestible fluorides, but there is a lot of discussion around that. And at the end of that particular hearing, it was raised by Senator Ashley Moody about illegal Chinese vapes coming in and its impact on oral health as well. So Senator Kennedy also acknowledged that he would be taking a peek at that particular product line. So a lot of interesting activity. I think we're kind of at the forefront of all of this new world. Food dyes were introduced by RFK recently and eliminated, or at least some legislation is starting to move forward to eliminate them from the American food supply. And now fluoride, oddly enough, who knew we were going to be so famous, but fluoride is coming online as a very hot topic. The last story of the night is really odd, frankly. It was posted actually by Howard Ferran, who owns and operates Dental Town, but he cited that a story out of Nashville where Nashville dentists are reporting a decrease in production and an increase in no-show and cancellations for their appointments due to ICE and deportation of illegal immigrants out of this area, or fear of being seen or heard. And so they're starting to feel the effects of deportation. So this must be geographically very specific in certain areas, and maybe Chad or some of our folks watching tonight that are on border communities or other areas that have heavy immigrant populations, are they also seeing a similar trend? I'm going to be honest, again, this was not on my bingo card. I did not think that we would have a story that correlated productivity of dental offices with ICE and illegal immigration. But once again, I'm continued to be proven wrong. And with that, that's the news.
As always, just a fantastic segment. I think I figured out the internet issues.
What was your dog sitting on the cord?
No. So I believe it was two competing firewalls on my new computer that were causing issues. But as we took a break, I went to just kind of did on a forum people having problems with StreamYard, and I'm not the only person that's having problems with StreamYard. Is it better right now or no? What do you want to talk about tonight?
Okay, so last week or 2 weeks ago, I put it out to our
Maybe.
private Facebook group, dental Facebook group, and I said, hey, if you could have an opportunity to create a video that would educate patients on certain aspects of what we do, or things you find that you're repeating yourself on a daily basis, what would it be? And we had a lot of votes for the oral systemic connection. And I thought that was a fantastic suggestion, because I do find that I push repeat on that conversation a fair amount on a daily basis in our office. So I'll give you just for instance, recently, pediatric patient came in. I'm seeing signs of erosion, bruxism, high cavity rate. Even while the patient's sitting in the chair, I can kind of hear some breathing issues going on. I don't know what it means. I don't know if it means it's a sleep related issue. I don't know if it means it's a nasal obstruction issue. I can't diagnose beyond the oral cavity, but I know something's going on, and I don't know how to solve it for the patient. So traditionally, as dentists, we identify a problem, decay, gum disease, whatever it happens to be, and we provide you a solution. Fix the cavity with a filling, a crown, do a deep cleaning to try to resolve bacterial overload in the gum tissue, whatever the methodology is. But what has actually been really severely lacking in dentistry, and I'm going to pick on our profession a little bit. When you go to a medical doctor and you say, I don't feel well, or you look a little off, you've been gaining weight, you're bloated, whatever you feel, anemia, look, whatever the symptom is, the first thing that they do is start to run tests. They check your blood, they have you pee in a cup, maybe they check your stool, they start taking images, radiographs, CBCTs, MRIs, PET scans, like whatever diagnostic information they need to ultimately make a diagnosis. And even then, I would argue medical doesn't always go back to etiology. They just sort of make a diagnosis and go forward. But in dentistry, we don't even gather all the diagnostic information. My point meaning, we don't study and examine saliva on a routine basis. We don't sample bacteria and send it off for analysis. We don't do genetic testing. So there's a lot of gaps, I think, in our current practice model that I'm hoping will continue to improve. A lot of great doctors are out there doing that. But patients want to understand, okay, great. You see grinding, you see acid exposure, you see a high cavity rate. Why? Do you get that a lot, Chad? Why? Why? I feel like I'm doing everything right. I exercise, I eat healthy, I only drink water, I don't eat candy. Like, they go through the whole thing, and yet they have, 5 cavities or whatever happens to be going on at the time. So I think dentists are genuinely very curious and trying to understand root cause of how we get to that point, because despite popular belief, most dentists actually want to prevent you from getting to that point. They would love to put intervention methods in place that would stop you from having cavities, that would stop you from having gum disease, that would, create an overall improvement in oral health. And even we as a profession are struggling for the data, the scientific correlations, the diagnostic testing mechanisms, and frankly, reimbursements that the insurance companies would recognize the value of understanding the diagnosis before the treatment plan in order to set the patient up for a better long-term prognosis. There's a big gap currently in dentistry that is going to have to be solved.
So I think that you hit on a lot of really good points, but I'm just going to kind of pick them apart real quick,
Yeah.
or I'm just going to zone in on a couple real quick. You talk about cavities, like 5 cavities. That was kind of what you said, but um, it used to be that it was like it was all related to sugar consumption, whether it's through sodas or, believe it or not, to mothers out there, juices and milks. And, yes, sweet tea has a lot of sugar in it. There's a lot of things that we consume, like, oh, well, I don't drink a lot of soda, I drink a lot of juice. Okay, well, yeah, that's going to cause cavities. All right. But sugar is part of the deal. One of the
Right.
things that we need to look into for cavities, and one of the things that I kind of want to hone in on tonight, is let's talk about the portion of the population. And it used to just be the elderly, but now medications are so much at the forefront. And I always tell my patients, the more medications you're on, if you look at a medication and you look at the list of side effects, it may say dry mouth down towards the bottom. Maybe side effect number 99 out of 155, or number 155 out of 155, whatever the side effects are going to be. They've got to label everything. But if you're on 1, 2, 3, 4 medications, no matter where the dry mouth is on the side effects, it becomes compounding as to the effect that the dry mouth has, that the medications have on the dry mouth. So, age leads to dry mouth, medications lead to dry mouth leads to tooth decay. There's a number of other factors rather than just sugar consumption. And so, quite
Can I
frankly, if
peel
you
that
have,
back? Can we peel that back just a
yeah,
second?
let's
Yeah.
go. Just a second. Yep.
So for co- completeness sake, I usually tell patients in a very simplistic way, and I think this is a really nice, helpful way to understand. Caries diagnosis or cavities or decay is usually a four-pronged disease. It is diet and hygiene, which we have some control over. It is biochemistry and genetics, which we have a lot less control over. So how do we define that? Diet, it is carbohydrate consumption and acidity exposure. Those two things are a lethal combination that will increase the rate of decay. And the rate of consumption is usually a predictor of that. So if you take a Coke and you have it at a meal, a couple of times a week, your risk profile is very low compared to someone who takes a Coke with a straw and sips it at their workstation for 4 to 6 hours at a time. It's that length of duration and exposure of acidity and carbohydrate simultaneously. Then there's hygiene, which I think the marketing companies have done a fantastic job of educating us on. It is brushing and flossing using fluoride, rinses, whatever, water picks, electric toothbrushes, special flavored flosses, the whole gamut of things. The key component is to remove the carbohydrate and the acidity biofilm off of the teeth so that it doesn't have the opportunity. Those are those little gooey colonies of bacteria that want to create problems. The biochemistry and the genetics piece is much more complicated. Chad, you hit it on the head with biochemistry. It's medications, it's salivary flow, it's an acidic profile. Some patients are just really acidic and they know that. They've had other issues with other women in particular, mucous membrane issues where they know they're running a little bit more acidic. They tend to have a high caries profile. It's actually gastric reflux as a contributor because we're creating a very acidic environment. So there's all the biochemistry things that are happening. Now there's a lot of correlation with gut biome and how healthy your gut biome is and how it contributes to oral health. So those are all biochemistry things that can be modified but are very difficult. And then there's genetics. And I don't think a lot of people appreciate or understand that there is a genetic predisposition, certainly to aggressive perio. But in addition, when moms and dads, grandmothers and grandparents kiss and love and share drinks and toothbrushes and other things that they do with their babies, they are colonizing that baby with their bacterial profile. And so there's all these compounding factors that are happening to any particular patient. And for most doctors, they're trying to understand where they can move the needle in order to help the patient get healthy again. And also, frankly, to alleviate some guilt because the marketing companies have done a really good job of making patients feel like if they just brushed and flossed every day using special products that they would no longer have cavities. And the reality is that if that were the case, Chad and I would have a lot less to do every day because it's such a complex disease profile. There are so many things that factor into that diagnosis. And we're honestly just peeling back the onion on how we can help patients work through those different modalities and where the contributory factors are. So I think it's really important for patients to understand that it is a four-pronged disease process. There's a lot of things that are factoring in to that diagnosis. And it is not just that you drink soda all day long or just that you eat candy. It's so much more complicated than that.
Well, and you bring up a really important point, and I loved how you said this because we talk about this. If I have a patient that comes in, I mean, we have in Texas what we call Dr. Pepper mouth, and Dr. Pepper, for some reason, when somebody comes in with a lot of decay, you can almost ask, "Do you love Dr. Pepper?" Nobody says, "Oh, it's from Coca-Cola." For some reason, people love to sip Dr. Pepper all day long.
Isn't
And
that
so
funny?
Dr. Mark Geisberger does a great job of talking about pH and neutralization. And so, an acidic pH is on the lower level and a basic pH is on the higher level. But whenever you drink a soda, it knocks you down to an acidic pH and that's where bacteria thrive, and that's where, we get all the destruction of the teeth. And so when you have an acidic pH, if you take a sip of a soda with a meal, your pH rises back to a more neutral level quickly. Whereas if you're drinking it all day long, your pH never really has the time to regulate your intraoral pH. And so that's going to lead you to more, you're going to be more prone to cavities. You also brought up something else. And so that's why, well, let me back up just a little bit. That's why when a patient comes in, if they absolutely love soda, there's a couple things that I'm not going to do. I'm never going to tell them right away, okay, well, if you love Coke or Dr. Pepper, do me a favor, switch to Diet Dr. Pepper or Diet Coke immediately and just sip on that all day long. Hell no. That's not going to really solve the problem. But
Nope.
one of the things that I will tell them is that the first way to cut it out of their diet or to diminish it from their diet is that limit yourself to a soda when you're eating a meal. Just do it when you're eating a meal. And you know what? The other thing that you don't want to do is as soon as you drink a soda, please, please, please do not think that you should just go brush your teeth right away. That can be extremely detrimental because the acidic animal, and that can be detrimental as well. So, make sure that you let it neutralize, drink water afterwards. Try and drink water throughout the day. Water's your best resource. I mean, water's a really cheap drug that's out there.
Okay, can we talk about water for a second? Because not all water is created equal, right? So let's talk about a few things about water. So water, first off, there's a great breakdown at COIS actually on water. The majority of bottled water is acidic, runs about 5.5 to 6. Why? Because they have to put EDTA in there to make it shelf stable. Otherwise, it would grow bacteria. So you can look for alkaline water sources. There are a few companies that do market alkalinity for their bottled water. Most tap water sources,
Core bottled water has an alkaline water, which is actually really good. And that's what I buy at the convenience store.
Yeah, I think Fiji and Evian too are also more alkaline in their pH. And then you can look at, a lot of them will market that they're pH neutral or pH basic. In addition, tap water historically is almost always around 7.2 to 7.6, which is fairly neutral. So I do try to encourage patients to consume tap water. It can be filtered. I'm perfectly fine with that, but it is more pH neutralized as actually opposed to bottled water. And honestly, folks that are suffering from dry mouth from medications and other issues going on tend to gravitate actually more towards bottled water, which is less hydrating because of this acidity level than just tap water. So just even making that very small change to filter tap can make a big difference. And then you have the discussion of fluoride, and at least tap water does offer the opportunity for fluoride, whether you believe in that or not. If you believe in the power of remineralization through fluoride, that it can take a small cavity and stop it in its tracks so it doesn't progress further, then tap water at least does also provide an additional source of fluoride exposure for those patients that are high cavity risk. So water is a really interesting debate because a lot of patients actually don't realize that the majority of over-the-counter bottled water is pH acidic and not online with Coke, but not too far from Coke.
Very, very good point, and that is something that I should bring up because we don't want to replace acidic drinks with acidic water. So
I know.
look for more alkaline. As a matter of fact, I suggest that everybody get a tube of pH sticks and just start testing everything.
Just test everything.
Test everything.
They're cheap.
Just test everything.
Just cheap. And honestly, you can test your own saliva. There are companies like GC has a great salivary testing kit. There are companies out there that offer that to dentists to be able to test saliva for patients. And it's interesting to see how acidic some folks are really running just naturally when they show up. And that gives you a lot of insight. So I don't think we've highlighted enough The bacteria that loves to cause holes in teeth, or the cavities that we have to ultimately fix, and the bacteria that likes to make a mess of your gum tissue, loves an acidic environment. It thrives in that acidity. So, as doctors, we've been trying to push towards more neutral sources of exposure. So, whether that's through rinses, toothpaste, your diet and hygiene, to try to get you more basic. Our belief is that that will then make you um, less caries risk. Now, cavity risk. Now, I would tell you, I've seen it work in our practice when patients make some of those fundamental changes in their acidity exposure. It does help, and it does reduce their decay rate for sure.
It just, as you're talking about this, I just decided that I would go to Amazon and take a look. And on Amazon, you can, for $10, and you would have it in your home tomorrow, buy some saliva testing strips. So there you go. There you have it.
Well, and I happen to be drinking an
Saliva.
Evian, right? I happen to be drinking Evian right now, and it actually says on the back 7.2 pH.
And
They're not
the
a
only thing
sponsor of the show, FYI, but maybe.
no, they're not. They're not. They're not. But hey, they should be.
Mhm.
There you go. So, hey, as we were talking about this episode and the oral systemic connection, um, I was kind of throwing out some questions to patients as to what they may have that we talk about. And
Yeah.
we kind of went tangential and talked a little bit about decay, but there were two topics. Well, there's three topics that I hope we could get to tonight. But one of the things that somebody had asked about, and this question came this afternoon, is what is the importance, or why would I need to take? I'm summarizing this for them, of course, but why do I need to take antibiotics before my dental appointment and other people in my family don't?
And
Did that cut out, or did that?
a little bit. Try
Well,
it
I
one
think
more
it's
time.
something that it okay, so as I'm watching this, I think it's just the StreamYard connection. I don't think we're cutting out on the
Okay.
stream, so it's just you and I, but I am gonna repeat it. So the question was, why would I need to take antibiotics prior to a dental appointment, and my family members don't?
Okay. Do you have an answer?
So you wanna talk about that a little bit?
Would love to.
Well, I think there's really two major. Well, I mean, there's several. So let's start with one that's kind of out of the ordinary, that I
Wait,
had something very interesting last week.
Chad,
A
really
patient with a
quickly.
heart and a kidney. Yeah,
Let's go to the origin story. Where did this all originate from?
a patient that had to take antibiotics and
No,
forgot
I'm
to take
sorry.
their
I
antibiotics.
meant antibiotic prophylaxis. What's the origin story of why patients started to take antibiotics? What were some of the known conditions that, if we go back 20 years, what have we been prescribing that for?
Oh, absolutely. Yeah, that's where I was headed before you so rudely cut me off. But actually, what we were talking about was I'm teasing, by the way. So let's look at, I think we could divide it into two main categories, okay? And there's subsets, of course, or other categories, but heart and joint. Would you agree with those two?
Agreed.
Okay. So both of those have undergone major changes in the past few years. And let me just put this disclaimer out there. This is up to the discretion of both your dentist and your medical provider, and not us. Okay. We're just going to state the facts as they are through the American Heart Association and the American Academy of Orthopedics, if I say that correctly, and the American Dental Association. So, where do you want to start, JB?
Well, I think we have to go back to help patients understand why did we write these prescriptions in the first place? And that was because it was believed and sampled bacteria was taken from both joints and bad hearts, valves, all these things that suggested that oral bacteria was clotting, coagulating, creating these bacterial uh, plaques from the oral cavity around these artificial things. And they were more likely to develop scar tissue and attract these plaques of bacteria. So we started writing prescriptions for an antibiotic prophylaxis, meaning you took an antibiotic before you came to the dental office to try to prevent that from happening. And there were patients that had major medical events and probably death associated with what they believed to be oral bacteria that created plaques in the hearts and around artificial joints that either failed the joints that were placed or created major cardiac events for that patient. So we as clinicians were sort of stuck between the orthopedic surgeons, the cardiologists, and the dentist trying to figure out how do we protect these patients but allow them to continue to seek care in the office. So we've seen, Chad and I have been practicing it roughly about the same amount of time, 20 plus years or so. And even in the short time that we've been practicing, it's changed about 10 times what we're supposed to be providing the prescription for. So carry on, Chad.
So, where do you want to start? Do you want to start on, we gave two subsets of categories. Do you want to start on heart or do you want to start on joint?
Oh, let's do joint. It's the most controversial.
Okay. And I would totally agree. Okay. So in 2014, the ADA Council on Scientific Affairs assembled an expert panel to update and clarify the clinical recommendations that were found in the 2012 evidence report and 2013 guideline, the prevention of orthopedic implant infection in patients undergoing dental procedures. Now, in 2014, they had the same findings as in 2012, and it was published in 2015 that they found no association between dental procedures and prosthetic joint infections. So in 2015, the American Dental Association Clinical Practice Guidelines states, in general, for patients with prosthetic joint implants, prophylactic antibiotics are not recommended prior to dental procedures to prevent prosthetic joint infection. So the reason that I bring this up is because as dentists, we know what we're told and we abide by what the ADA tells us. But I can personally say that if there's ever a question, I default to the orthopedic surgeon that placed the joint and I want their recommendation. The first person and the easiest person to blame is always the dental professional, because there's just been this horrible misunderstanding that everything that we do throws bacteria into the bloodstream and has the potential to attack a joint or a heart valve or something else. And therefore, that would lead to the deterioration of said joint or heart valve or pre-existing condition that we'll talk about in just a minute. And so I always defer to the orthopedic surgeon. Now, there is minimal evidence to support that this is the case, as stated in the 2015 report. But once again, we are never going to, at least I am never going to, overrule what the orthopedic surgeon says, and I'm never going to question a patient. And so if the patient requested and if the orthopedic surgeon suggested, then I will prescribe the antibiotics prior to the appointment. Anything to add to that?
Yeah, a few. So the first thing I would say is my biggest issue with this prophylaxis for life, which we've seen from orthopedic surgeons, and this kind of ongoing battle between dentists and medical professionals and the orthopedic surgeons goes back to my original discussion about the fact that we're not looking at the systemic oral connection. Because the problem is, as opposed to knowing the patient and doing a salivary profile, understanding the inflammatory conditions, are they a perio patient? Are they a cavity patient? Are they a super healthy patient? We take this very shotgun approach that basically anyone that has a mouth must have the same risk profile. You and I know, having treated tens of thousands of patients over the course of our career, they don't all present with the same risk profile. So there are definitely patients that come in that I think probably antibiotics for life makes a ton of sense because they have rampant aggressive periodontal disease. They have a lot of other compounding issues going on. I'm all in on that. But then the patient who comes in who's never had a cavity, never had perio disease, is compliant on their recares, is showing no evidence or sign of oral systemic disease connection. I just have a really hard time of that shotgun approach of like everybody gets the same treatment. So again, all I can say, I'm not judging the orthopedic surgeons, I'm not judging the dentist. What I'm saying is
Absolutely.
we're doing a disservice by not looking at the whole patient from the get-go and having a holistic approach about who they are, what risk factors they have, and why some would benefit from antibiotic prophylaxis and some wouldn't. And I would just say, carefully, because I'm probably going to get sued for this, but this all comes down to tort reform. If every doctor didn't believe that every decision they made would not cost them their license and that they were doing it with the best intent for that patient, sometimes they're right and sometimes they're wrong, but they're doing the best they can with the information they had, then you would see a lot of this stuff change. And you would see us go more patient directed care, trying to do the very best for the individual sitting in front of us. But we use these shotgun approaches because, from a liability perspective, it appears to be safer to treat everyone the same as opposed to differentiated care. And as a clinician, it's really hard to swallow. It's very difficult to practice under those parameters.
It is. And once again, I always recommend if you've got a patient that is, or if a patient is high risk, patient has, multiple comorbidities, multiple issues, always get a medical consult prior to treating that patient. And as a patient, that's something that you should ask your dentist for. I had a patient that came in a couple weeks ago with both a heart and a kidney transplant. And the first people that I'm going to speak to are the transplant surgeons for each of those organs and discuss, is there anything that we need to alter in our course of treatment, or what do you recommend? And of course, both of them recommended antibiotic prophylaxis, and I'm certainly not going to argue with that. I mean, this patient's a high risk patient from the get-go, and the patient, most patients who have undergone a lot of medical care, a lot of surgeries, are very open to a medical consult prior to us commencing care, because we're looking out for their best interest. And I think that you should ask your dentist to look out for their best interest as well.
All right, so antibiotic prophylaxis for hearts. Go.
Yeah, so that's a different one, and that's changed quite a bit. So what I'm going to do is I'm going to go to the most current infective endocarditis or valvular heart disease guidelines that states the use of preventive antibiotics before certain dental procedures is reasonable for patients with prosthetic cardiac valves, prosthetic material used for cardiac valve repair, a history of infective endocarditis, a cardiac transplant with valve regurgitation due to a structurally abnormal valve, and the following congenital present from birth heart diseases: unrepaired cyanotic congenital heart disease, including palliative shunts, and conduits, and any repaired congenital heart defect with residual shunts or valvular regurgitation at the site or adjacent to the site of a prosthetic patch or a prosthetic device. And so it's really a little bit wider on cardiac disease. They've narrowed it down somewhat. I always believe that the first 6 months after cardiac surgery are the most critical, and that's what we're taught. And so we should avoid any dental treatment within the first 6 months post myocardial infarction or post cardiac surgery, if at all possible. However, when in doubt, seek a medical consult from the cardiologist or the cardiac surgeon, cardiothoracic surgeon.
Couldn't agree more.
Yeah. And if a dentist elects to postpone treatment due to your medical history, don't be upset, be thankful,
Yeah.
because they're just looking out to figure out what's the best way to treat you. And we can all say that we've had patients that have come in and, we've said, "Hey, before I do anything, I'm going to consult with your physician or your team of physicians." And yes, that's a CYA type of deal, but that's also looking out for your best interest, because we don't want to do anything that could adversely affect the treatment outcomes that you've achieved from your previous medical team or your co-treating medical team.
Yeah, and the other big piece that I continue to find challenging is that the medications change constantly, and the names are changing, and the side effects and the contraindications for different things. So take semaglutides, for instance, a super popular drug on the market right now. You know them as Wegovy and Ozempic and a few others that are out there, and there's a lot of generics as well. It took a little bit of time for folks to be on those medications to find out that they actually have pretty significant issues with sedation. And now, as part of a sedation protocol, whether you're at an oral surgeon, in a dental office, doing sedation for crowns, cavities, etc., or in an OR setting, they want to know if you are on a semaglutide or if you've been on it, or a GLP-1. And the issue is that it is affecting the way that these patients are sedating, and it's not safe. And so it is important that we understand those risk factors before we go in. And in fairness, we're learning that now, and it's only because we've had such a giant cohort of patients to be on these GLP-1s that we now know some of the challenges that are starting to show up for patients that have had adverse outcomes, either in surgery or sedation. So bear with your dentist and your doctors as they continue to try to stay up to date with this ever evolving pharmaceutical evolution that's happening, where new drugs are coming out all the time. We have cohorts of clusters of drugs that we understand, but there are a lot of new ones that come online all the time. And we don't know all the side effects of those drugs yet, and are continuing to try to stay up to date. We also just don't know all the name brands. There might be, for instance, if you take a GLP-1, currently, I think there's 4 or 5 major brands on the market today that's all kind of fall in the same bucket. And so, doctors are trying to keep up with all of these different brands changing. The other challenge that I think dentists and doctors continue to face is the polypharmacy. What is the overall impact of a patient taking 4 plus medications, 10 plus medications? And, what surgical impacts might we see? Increased bleeding, delayed healing, more pain, more discomfort, not anesthetizing well during a procedure, issues during sedation. And doctors and dentists need to be aware of those things. So, we're learning as quick as the information is coming out, but it is incredibly challenging to stay uh, up to date by the minute, literally, on what's happening in the pharmaceutical world.
Totally agree. And you mentioned something about the GLP-1s and stuff like that. There's also new regulation that there are a bunch of off-brand and compounded
Oh,
GLP-1s,
I
and I
know.
believe they're shutting down, or I should be shutting down. but they're actually making it harder. Um, I don't know the laws, but things are changing. You're not going to see as many from compounded pharmacies as you have in the past, and so the regulations are becoming a little bit tighter on those because I don't know that it was as heavily regulated as it is becoming now. It's real interesting environment that's going on in the GLP-1 world.
Yeah, agreed.
Um, so we're running out of time, but I think there's one more thing that we need to talk about. We've talked about some interesting things tonight, but you know, um, one of the things that patients may or may not understand is why in the world would your dentist be asking you questions about the way that you sleep? And I just want to read a little excerpt here that I think might help explain that. Um, the American Dental Association, you'll see that there's a lot of references to the American Dental Association, which this is in 2017. Dentists are encouraged to screen patients for sleep related breathing disorders as a part of a comprehensive medical and dental history to recognize symptoms such as daytime sleepiness, choking, snoring, or witnessed apneas, and an evaluation for risk factors such as obesity, retinopathy, or hypertension. So basically, in 2017, the American Dental Association recommended that dentists start screening their patients for sleep related breathing disorders. And so all of our patients may have heard about, CPAPs or, devices to help them sleep, dental devices that will help them sleep better. But really, ultimately, the goal of all of that is to help you breathe better. And so, JB, you want to talk a little bit about that as well?
Yeah, no, I think as I referenced in the beginning of the show, when we see patients that come into the office and we see signs of grinding, we see signs of erosion, we see signs of high cavity rate, we look in the back of the throat and we can often not visualize the airway space. We see giant tonsils occluding the airway space. Sometimes we can even hear the patient, and how they're breathing when we force them to open their mouth and stay open for long periods of time. You can start to actually really appreciate how people are oxygenating even during the daytime. So there's a lot of information that's being garnered by the dentist when they're sitting down and doing those exams, and they're sort of processing all these pieces of information. And what we have found is that number one, a dental office can be a great first screening opportunity to observe those issues that may be going on and to start engaging patients on conversations about whether or not they're also observing the same things. Now, in full disclosure, most dentists are not treating those. So, first off, you should understand that a good number of us are identifying and observing those for no financial gain whatsoever. The majority of us send you back to your primary care physician with a referral in hand stating that you really should present for a sleep study and do further investigation. There is a subset of practitioners that provide oral appliances, but it's certainly not the majority of dentists in the marketplace today. So, dentists that are screening for sleep dentistry or sleep apnea issues or concerns with sleep related breathing disorders often are doing it truly altruistically because they care for their patients and they want them to be healthy. And they recognize that while healthy teeth are a really important part of the overall health of the patient, if they're not breathing well and not oxygenating well, these patients have a compromised life expectancy, compromised delayed development for pediatric patients. They might not hit all their growth trajectories as they're supposed to. So we're playing an important part in the healthcare part of the relationship with our patients. So we see a lot of things, we engage in those conversations. Honestly, a lot of times patients finally feel validated that they're feeling the things that they feel, but couldn't articulate it or haven't been able to get a physician to engage on the conversation. And we send them back armed with more information to hopefully get a deeper diagnosis. There's a lot of benefit for dentists to be doing sleep screens to make sure that patients are breathing adequately and are taking care of that airway.
And I think it's safe to say that it varies from state to state as to um, the extent to which a dentist could treat sleep related breathing disorders. Um, but, you know, regardless, if your dentist is in a state and they're asking you these questions, I would definitely seek a medical consult. In my practice, I always refer to an ENT, recommend a sleep study, and you know have them evaluate options through the MD as to what are the best ways that they could be served in treating their sleep related breathing disorder. We are screening. We're not all treating, but I think that dentists should be screening for sleep related breathing disorders or looking for some of the signs that our patients present with these particular disorders.
Again, I cannot stress enough, it's a holistic and whole body approach to all aspects of your medical care. So we should all be looking at it through the giant lens of what I see could be correlated to something going on in parts that I don't treat, but I would also challenge that physicians should be doing the same. What I see might have a current impact on the thing that I can treat, but there's likely contributory things that are going on in many other areas of the body that also play into this diagnosis. So we cannot be we become so compartmentalized in medicine, and we only look at the thing that we know how to fix instead of the whole person sitting in our chair who oftentimes is presenting with something that we can see and diagnose as dentists, but there's some contributory issue or underlying systemic cause that is going on. And we just happen to be the one to be able to see that particular manifestation of it. So, for patients, it's advocating for your own care to make sure that all of your clinicians are talking to each other. That the clinicians you have chosen to be a part of your system treat the whole person and not just one organ of your body. And then for practitioners, like really stressing seeing beyond the oral cavity and looking beyond teeth to make sure that you appreciate the etiology of the things that are manifesting themselves in the mouth so that you can be a participatory member of the healthcare team for that patient and seeing them as a whole person and not just teeth.
I think that is a great way to close. And so I have two closing comments. And that is that the oral microbiome affects the gut microbiome, and the gut microbiome affects the oral microbiome. And there is a huge relationship between the two. It's something that we should all understand. There is a great company out there called Viome. They are not a sponsor of the show, but they have a great testing kit that you can learn a little bit more about what's going on within your body. And they can make recommendations to improve your overall health, allow you a better chance to fight certain diseases and cancers and so on and so forth. So look into Viome if that's something that you're interested in. Once again, not a sponsor of the show. It's just a company that we believe in, and I love what they're doing for the overall health and well-being and also the oral health of our patients. And the last thing that I want to close on is that if you have a complicated medical history or you have any medical history at all, don't ever be upset with your dentist for asking to do a medical consult prior to treating you. Be thankful that they're taking the extra step to make sure that they're treating you in the most appropriate, the most effective, and the best manner possible, because they're looking out for your well-being and not just theirs. So be thankful that you're in the hands of a dentist that's so caring and wants to really understand you before they just pick up a handpiece and start drilling in your mouth. So want to thank everybody for listening tonight, and until next week, have a great evening.
And that wraps up another podcast for Dentists behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.